So in today's session, we'll discuss about the topic early nutrition, programming and future diseases, chapter 42, page number 542, 542. Okay. Those who are joining late, please help them out with the page numbers. So early nutrition and programming, this is about soon after the birth and also when the child is still in the mother's womb. Okay. What nutritional uh, help we can do so that the child does not have the risk of developing certain adult diseases. Okay. So early life, we consider it as the first 100 days of conception. So any malnutrition that takes place during this time period is also harmful. Okay. And also during the fetal life as well. If the mother is undergoing malnutrition, it will also put the fetus to a myriad of lifestyle diseases like diabetes mellitus, cardiovascular diseases, obesity. We'll see that later. Okay. So early life nutrition or first 100 days from the conception to the age 2, okay, we consider it has a significant uh, phase of human life, okay, which may have a very lasting impact on the development of tissues and organs, okay. So these effects are known as programming, we call it nutritional programming, okay, because you're programming the human body to have or not to have certain diseases after a period of time. Okay. And they have significant risk factors for developing chronic illnesses in adulthood. Okay. So, programming for obesity, what we have understood based on certain researches, what we have understood so far, that what happens in the fetal life or during the postnatal period, what happens that puts a individual at a risk of obesity in the future. Okay, just 1 minute. So, the first is fuel mediated in utero hypothesis. So, according to this hypothesis, during when there is excess fat, okay, when there is excess fat in the mother's womb, or in the mother's body, that excess glucose will be converted into fat, okay. And when there is too much of fat in the mother's body, fetus will also gain that fat, okay. So it will lead to large fetus, big baby, okay, while birth, even during the pregnancy. And this big baby will definitely have more adiposity, putting the child to a risk of developing diseases. Okay. So this is about the fuel mediated in utero hypothesis. Having the nutrition of the mother during her pregnancy, okay, if she is overeating or she has gained excess of weight, this can lead to obesity in the child. Okay, obesity in the fetus, and a obese fetus or a big baby who has a lot of adiposity definitely will have a higher risk of developing obesity when they grow up. Okay, It is kind of a rebound obesity. You are born as a large baby with lots of adipose cells. You grow up as a large baby with a lot of adipose cells which stretch, get bigger and bigger. Okay, so that is adiposity. Is it clear to all? Is this hypothesis clear to all? Next is accelerated postnatal weight gain. Accelerated postnatal weight gain after birth. Okay, this is after birth, postnatal. Okay, so what's happening here is too much of food after the child has been born. Okay, too much of breastfeeding, over breastfeeding. After 6 months, also, too much of weaning diet. That is excess of food. The child will rapidly gain weight, and that it is difficult for a child to lose weight. Okay, once it is used to overfeeding, it is difficult for parents to go back. Okay, so once the child forms this, it forms into obesity. Okay, over rapid weight gain soon after birth is also too bad. There is a steady increase in weight gain. According to the growth chart, there is a steady increase in the weight gain that has to be maintained. If there is rapid increase in weight gain, that is also too bad. So that is after birth, when a child is born, you overfeed the child. Okay, overfeed the child. Even if the child is not hungry, you are feeding. You are forcefully breastfeeding the child, forcefully feeding the child during the weaning phase. Okay, all these things will lead to accelerated postnatal weight gain. Next is mismatch hypothesis, which means there is a suboptimal prenatal and obesogenic childhood environment. Okay, like the child is born in a family that eats, let's say, for example, eats a lot of ghee. Okay, the family eats a lot of saturated fats. Okay, that is very common in the child's household. Okay, in these kind of situations, what you get is a child who is in an environment that supports obesity. Okay, so that is what we call as the suboptimum environment in which the child has got obesity. Not just obesity, even the other comorbidities that is hereditary available to the child. Okay, before during pregnancy also the mother was having a lot of ghee, a lot of saturated fat. Okay, the mother was being overfed because her pregnancy, and even after the child is born, the child is still in the same household that is using a lot of excessive eating practices, certain food practices, certain lifestyle practices which supports the risk of obesity. Okay, so this is the mismatch hypothesis. Is all the hypothesis clear to all? Next is postnatal risk factors. What are the risk factors after giving birth you may have which would support obesity? Okay, what are the risk factors after birth which may support obesity, future obesity in a child? Okay, so first is the faster weight gain in the first 6 months. As I mentioned earlier, okay, accelerated postnatal weight gain hypothesis. That's the same thing here. There is a trend, a steady trend that mothers should follow. Okay, when it comes to the child's weight gain. Okay, growth chart and everything has to be referred. That steady, the mothers and the child has to be in that steady trend. Okay, if you are jumping the ropes, you are overfeeding the child. Okay, the child is gaining weight super rapidly in the first 6 months of life, which means child is born with adequate amount of adipose tissues which are stretching and stretching in that little body. There are lots of adipose tissues that are just keeping on multiplying, and whatever are the existing adipose tissue, they are keeping on stretching, okay, making the child bigger and bigger. So there is a very fast rapid weight gain in first 6 months of life. That is the first uh, signal that you get that this child may suffer from metabolic diseases. Okay, the child may have a lot of adipose tissue, visceral adiposity, a lot of fat around the organ. The child will also have insulin sensitivity, okay, high blood pressure later in life. These conditions, okay, these conditions are favored when a child's birth weight increases rapidly in the first 6 months of life. Okay, usually by the first 6 months the child's weight should double. Okay, but if the child is weighing around triple the weight of their birth weight. Okay, for example, a child was born with 2.5 kg. Okay, by the 6th month the child is more than 6.5 kg. It means the child has had a very fast weight gain and too much of weight gain. So this weight gain, this high weight gain, fast weight gain, will say that this child has a high risk of developing insulin sensitivity, blood pressure, okay, visceral adipose tissue, that is fat around the organs. Okay, these will be quite high in this child later on in life. Okay, that is one risk factor after birth. Then you have the postnatal weight gain factors that favors cardiovascular diseases, diabetes mellitus, obesity. Okay, but when there is a rapid postnatal growth during childhood as well. Okay, for the first statement is about the first 6 months. It doesn't stop there. Okay, even after the in the first 6 months, your baby was having a normal weight. Okay, by the first birthday or in the early childhood, the child became obese or overweight. Okay, and even during infancy, first 6 months was okay, all right, normal. But when you started the weaning diet, the child had put on a lot of weight rapidly. Okay, what's happening here? The same thing. The child is again at the risk of cardiovascular diseases, diabetes mellitus, obesity, etc. Okay, so overfeeding and understanding that a chubby, healthy child who has some weight on their body is not always good. Okay, in long term. Then you have early feeding or overgrowth associated with hyperinsulinemia, hyperleptinemia. Okay, leptinemia is that's the hormone that makes you hungry. Okay, so when there is too much of leptin in your blood, you will always be hungry. Okay, it kind of leads to food addictions. So when you are overfeeding the child at any stage of their life, okay, overgrowth is usually associated with these conditions: hyperlipidemia, hyperlipidemia, that will again lead to diabetes, overweight, obesity issues. Early adiposity rebound in BMI curve resulting in obesity. Okay. Early adiposity, the child was born with a lot of adipose tissue. The child was slightly overweight. Okay. Even though the child loses some of that adiposity, doesn't mean that the child will not be obese. If you are born with a lot of adipose tissue, you are naturally at a higher risk of developing obesity. Okay. So these are the risk factors of postnatal risk factors of developing obesity. Is it clear to all? Next is fetal programming and origin of adulthood diseases. This is four. Okay. Fetal programming and origin of adulthood diseases. On page number 545. So what is fetal programming or FOD? The concept of fetal origin of adulthood diseases, now it is being studied well beyond just coronary heart diseases. Earlier, it was about coronary artery diseases. Will this child have coronary artery diseases or not in the future? That was the motto earlier. Okay, but now it is not like that. Now it is much more than coronary heart diseases. Okay, we want the risk factors of other diseases as well. Okay. Being a risk factor of coronary heart diseases just not enough, okay, for fetal for programming. Now investigations about disease conditions in central nervous system, okay, mental health diseases, cognitive function, all these phases of a human health can also be traced back to fetal for programming and fetal origin. Means when the child is still unborn, okay, during your fetal life itself, there are certain tests that we can do to identify what kind of disease conditions this child may have in the future. Okay. By understanding fetal origin of adult diseases, healthcare professionals and policymakers can also issue high healthcare priority and implement preventive measures and treatment for those at higher risk of chronic diseases. Okay. When you understand that your country has a risk of certain disease conditions, children born in this state or children born in this part of the country, okay, naturally have a risk of certain disease conditions. What you can do here is, as a healthcare policy maker or healthcare professional, you can guide the mother to have specific kind of diet. Okay, you can guide the mother that after the child is born, okay, don't force feed the child. Okay, a healthy baby should be having a normal weight, neither overweight, neither underweight. Okay, so these kind of lessons should be given to young mothers. This will come under preventive strategies as well. So next you have is the Ford hypothesis that holds that events during early development have profound impact on one's risk of development of future adult diseases. FOAD, what do you mean by FOAD? FOAD, that is fetal origin of adulthood diseases. It implies that this is a hypothesis that tells that during the developmental stage of a fetus, okay, during that stage itself, what is the risk of future diseases can be understood. So technology is that advanced these days. Okay, there are different kind of uh, graphs, test, okay, ponderal index, Hertfordshire birth cohort. Okay, these are some studies and some indexes which can show you the association of how a fetal nutrition or fetal health is associated with certain adult diseases. Even if you take the blood sample of a newborn baby, certain lipids that are present at birth in the child's body, certain types of fat present in the child's body, can give you an insight that what kind of disease condition this child will have in long term. Okay, the thickness of their blood vessels, the thinness of the blood vessels, okay, the different layers of the blood vessels. These can be examined just by using ultrasound. Okay, and thinning of the blood vessels, which usually is associated with cardiovascular diseases, is usually seen with children who are low birth. Okay, so if you know somebody was a low birth weight baby, man or woman, okay, or if a woman has given birth to low birth weight baby, naturally this child will have increased risk of cardiovascular diseases in the later stages of its life. Okay, and usually they tend to be, they also can put on a lot of weight. Low birth weight babies can put on a lot of weight as well if there is access of nutrition. And children who were heavier at birth, okay, they also tend to become fat as adults. Low birth weight, is a surrogate marker for poor fetal growth and nutrition. And if a child is low birth weight, the problem doesn't stop there. Even if you are able to save a low birth weight baby, okay, a child is born with low birth weight. You put the child in ICU, all the care is given, the child survives. Okay, it doesn't stop there. The child is surviving with a high risk of coronary artery disease, hypertension, obesity, insulin resistance, and all. Okay. So these disease conditions are not just associated with children who children who have a heavy birth weight. Okay, it's also associated with low birth weight babies as well. Is it clear the introduction of Ford to all? Now, next is Baker hypothesis. This is an assumption. Hypothesis means it's an assumption. Okay. Still have to be proven. This is an assumption, a theory that we make. Okay. It has to be proven in the future. Okay. Or it can be proven right now as well. Okay. So according to Baker, he's a scientist. Just a minute. So according to Baker, the hypothesis implicates that the fetal in utero environment is a significant determinant of risk factors of major chronic diseases, such as cardiovascular diseases, stroke, hypertension, type 2 diabetes, obesity later in life. Just now, what we had discussed so far. Okay. The hypothesis you can understand just by looking at this image. Okay. So, this is a pregnant woman who has an adequate nutrition. Neither she is underweight, neither she is overweight. Okay. The pregnant woman is adequately nourished. So the fetus is also well nourished. Okay. Now she gives birth to a well nourished baby, normal weight baby. Okay. This baby grows up into a healthy, well nourished, adequately nourished adult with low chances of disease conditions like CVD, stroke, hypertension, type 2 diabetes, etc. Okay. Now see, look at this second image. Okay. If you see the mother, if you see both the mothers, okay, do you see any difference here? Image one and image one is the top one, image two is the bottom one. Okay. Inside her, there is a baby, which means this is the pregnant mother. Okay. When you see this, both mothers, do you see any difference here? In weight wise or body build wise? Yes. One mother is malnourished. Okay. Baker hypothesis, they use this kind of diagram to make you understand. Okay. So this is a malnourished mother. And do you see the size difference in the baby as well? Is there a size difference? Do you think that the child born to this malnourished mother is also smaller in size as compared to the healthy baby born above? So big baby is for well nourished. Malnourished mother has given birth to a small baby. Okay. Low birth weight baby, small for gestational age baby. It could be anything. But the size of the baby, you can see how tiny this baby is as compared to the baby that is born above. Okay. But once this baby starts taking too much of nutrition, growth catch up has to be done. But even after growth catch up, it doesn't stop there. During their childhood, during their adolescence age, there was a chance of high energy intake, high caloric food intake. Okay. So even though the child was born to a malnourished mother, now the child has become an adult, but an adult with a risk of, you can see this last image here. Okay. Caricature here is quite wide, rounded. Okay. It's not a healthy caricature. Okay. It is not even adequate height. There is not even adequate height. Growth, which means there was a growth retardation, because low birth weight babies have a risk of growth retardation. Okay. So there was a growth retardation. On top of that, obesity, hypertension, type 2 diabetes, cardiovascular diseases, all this risk will start because the child does not have enough height, the adult does not have enough height for their weight. Okay, so this is the Baker hypothesis. Is it clear to all? Next is the thrifty genotype and thrifty phenotype. Okay. So another name is there. Okay, genotype, thrifty genotype is the fetal origin hypothesis, and phenotype, thrifty phenotype is the other environmental factors, insulin resistance and all. Okay, so thrifty genotype is your genetics. Okay, it is your genes that trigger a lot of insulin. You are born with this gene. Okay, maybe you were in a fetal environment. Maybe the mother was suffering from gestational diabetes during pregnancy. Okay, these could be the reason the child has been born with a certain genotype that puts the baby at a risk of developing insulin resistance. Okay, usually it is seen in mothers with gestational diabetes and all. Okay, and usually, we Indians also have this ability to store food rapidly as fat. This is seen in these children. Okay. Immediately, whatever they eat becomes fat. It is not used for energy. Okay. It is used for storing. Okay. That is seen here. It becomes fat which is saved for future, but even if it is used in the future or not, all the fat in the future also will be stored as fat. All the energy will be stored as fat, not converted into energy. That's why people become diabetogenic uh, in today's generation, where we have enough access to food. There is enough access to food. Okay, but there is no control over the appetite. So whatever we eat becomes fat and it is stored in the body. It is not converted into energy. So a child who is born with a thrifty genotype because of certain fetal environment, fetal malnutrition, genetics switched. Okay. There is a child who has been born with low birth weight because of fetal malnutrition and because of this genetics. Okay. Now this genetic will show in form of the physical characteristic. Okay. What is the physical characteristic here? The child will have insulin resistance. Okay. And other metabolic disorders. Doesn't matter if the child comes from a developed country or an underdeveloped country. When there is nutrition, automatically the child's body goes into a stage of insulin resistance. Okay. So that becomes the fetal insulin hypothesis. Okay. From thrifty genotype, which happened because of malnutrition, now you have a low birth weight baby who has a physical characteristic of a low birth weight baby. Okay. Who can't break down carbohydrates properly, and there is an excess of nutrition. Now the thrifty phenotype will start acting. Okay. There will be insulin resistance. And because of insulin resistance, slowly other inflammatory conditions will start, and the child may suffer from diabetes, cardiovascular diseases, stroke, obesity, and all. Okay. And usually this happens in affluent societies. Okay. Even in affluent societies, if the child is born to a poor family, okay, with like the child is low birth weight, born to a poor family, but with economic rise, okay, the family got rich, there is access of nutrition, but the child was still a low birth weight baby, okay, with a specific genotype that is supposed to store fat. Okay, when you are malnourished, your body goes into a situation that we may not get food tomorrow, let's store what we have as fat for a better future. Okay, body is in that state. Okay, and tomorrow even if you become rich, this genetics will not change. Okay, your body is always in a mode to store food as fat. Because when you were born, you were low birth weight. You were undernourished. Your body needs to survive. The body was in survival mode. The body today is also in survival mode, irrespective of your economic improvement. Okay. You were poor when you were born, but right now you are rich, you are modern, you have access to the nutrition that will not change your genetics. Your genetic was in survival mode to store fat. Okay, right now also the same genetics will play out to store fat. So whatever you eat, it becomes fat. Okay, so there is an inherent risk of being obese. Okay, along with obesity comes insulin resistance, stroke, CVD, diabetes mellitus, and all. So this is a thrifty genotype, thrifty phenotype hypothesis. Is it clear to all? It is just making sure that you don't overfeed the child. Even if you are in a good economic state and all those things, overfeeding should be avoided. Okay. So here you can see thrifty phenotype, small babies. Okay. Because of malnutrition in the mother, small babies are born, small thin babies are born. Okay. Their body is programmed in such a way that they have to store fat. Okay. So naturally they are susceptible to insulin resistance, type 2 diabetes, heart disease in the future. Okay, so this is thrifty phenotype. Thrifty genotype, small babies who are born, they have genes that influence insulin secretion and action. So naturally, small babies are also susceptible to insulin resistance, type 2 diabetes, heart disease, and all. Okay. Next is fetal insulin hypothesis. Fetal insulin hypothesis. So this is hypothesis again theory. Okay, theory yet to be proven. Okay, so this hypothesis leads to identifying who is at a risk of type 2 diabetes, adult onset type 2 diabetes. Okay, not a type 1, type 2 diabetes, adult onset diabetes. Which children born today, right now, has the risk of developing type 2 diabetes when they become adults of tomorrow. Okay. So we have the thrifty phenotype hypothesis that comes from the family. Okay. Because mother was malnourished, there was no good supply of nutrients. Okay. The child became small. Okay. This was a small baby, low birth weight baby. Okay. And because of this intrauterine programming of metabolism, because even when the mother was pregnant, the child was growing. The mother was also pregnant in scarcity of nutrition. Okay, so the fetus is also developing in the same scarcity of nutrition. Okay, so the child's body even before birth was in a survival mode. Okay, mother is not getting enough food, whatever food we have has to be stored as fat. Okay. So metabolism was programmed like this before birth. Okay. These children have a risk of type 2 diabetes. Next, from the fetal insulin hypothesis, the child is born with certain genes that influence the child's insulin secretion and action. This is the genotype hypothesis. Okay. Certain children are born with genes, especially children born to gestational diabetic mothers, children born to very affluent families who have access to nutrition. Okay, children born in those families, they have the genes which affects their insulin secretion. Children who are born to diabetic mothers and all. Okay, children who are born to families in which diabetes is very common, both the grandparents from both the sides, both the parents have a risk of diabetes. They are born with genes that will influence their insulin secretion and action. Okay. So that will lead to fetal insulin mediated growth. Less fetal insulin will be there. Okay. That will affect the child's growth. And also, there is a reduced capacity of insulin to function properly. If insulin is not functioning properly, definitely when you become an adult, there are high chances you will get type 2 diabetes. This is the fetal insulin hypothesis. Then we have the small baby syndrome, okay, a stunted growth, intrauterine growth restriction or retardation, IUGR, okay, is when a baby in a womb does not grow as expected. That is IUGR. So baby is not big as it is supposed to be during the state of mother's pregnancy. Every month, a child should grow up to a specific size and weight. Okay. When this growth is not as expected, is not up to the mark of the specified size and weight, that's when we say it's a intrauterine growth retardation case. Okay. So this timing is known as unborn baby's gestational age. Gestational age means the timing of pregnancy. Okay, what is the time of the how many weeks the mother is pregnant? That is the gestational age of the child. That is the age of the child. Okay, if you are giving age to an unborn thing. Okay, so that is what we consider as gestational age. So here you can see a healthy baby and an unhealthy baby or intrauterine growth retardation baby. How small they are as compared to the baby of the same age. Okay, both may be age wise same of the same weeks, but size wise they are very different. So how it happens? It could be because the child is not getting enough oxygen or nutrients. Malnourishment is there in the mother. Okay, and some nutrients are not sufficiently transferred to the fetus through placenta. Okay, if the placenta is also not functioning properly, if it's a healthy mother but placenta is not functioning properly, that could also lead to intrauterine growth retardation. It leads to fetal hypoxemia, restricted fetal growth. It affects at least 10% of the pregnancies all over the world. So complications, mothers may go into preterm labor. Mothers may suffer from preeclampsia. A child born will be IUGR, intrauterine growth retarded baby, who will have some complications to catch up. Okay. High risk of stillbirth, babies who are born without life. Okay. So risk factors, which mothers have a risk factors of giving birth to an IUGR baby or small baby. Okay. Um, Mothers who have high blood pressure during pregnancy, smoking, alcohol consumption, drug abuse, primiparity, which is if you're pregnant for the first time, you're a first time mother. First time mothers have a risk of developing this. Okay. Advanced maternal age, getting pregnant after the age of 35 or around 35 or about 35. Okay. You had a history of IUGR. Okay. You may not be a primipara. You are not a first time mother. But previously, when previously all of your pregnancies, you gave birth to an IUGR baby. Okay. Use of anti-neoplastics, anti-epileptics. Okay. These are anti-cancer medications, anti-seizure medications. If the mother is suffering from eclampsia, she will be put on anti-epileptics. Okay. So that she does not go into seizures. Okay. Neoplastics are used in chemotherapy and all to prevent tumor from getting malignant. Okay. So mothers who are on these medications are also at the risk of developing IUGR baby. So that's about fetal malnutrition. Is it clear to all the hypothesis?